would like to thank the organizers for the opportunity to tell you a little bit about this study and how Mayo is actually beginning to integrate genomics into the care of breast cancer patients. Before we begin, I just want to mention that there are a lot of people that have been working on this particular project. As you can see, the team of people that are up here really does take a lot of people to put together team science, and that's exactly where we're going to tell you a little bit about the story today. And before we begin, I want to just say a note here, and I'm just going to show you the learning objectives. You have those, and you can go through those, and we'll be addressing each of those objectives throughout the talk. One of the things that I want to focus on is this idea of precision medicine. And I use this term. I went online and I found it right away from Wikipedia, so I'm going to show it to you here. Application of omic analysis and system biology to analyze the cause of the patient's disease and to utilize targeted treatments to address the disease process. So I think all of us are here today in part because of this idea of precision medicine. And in the case of breast cancer or any type of malignancy, you could think of it relatively simplistically. And when I say simplistically, that is the idea of here's the cancer, we'll analyze the genome, and we'll simply come up with the best therapy. And you can see on the right, there's a woman who's undergoing chemotherapy. Presumably, she's getting the best therapy to treat her cancer based on the genomics. And that really is our goal. But to try to really understand this and to introduce this, you actually have to know exactly where we came from. And where we came from is the fact that in this case, in the treatment of breast cancer, but substitute your favorite cancer here, and that is the fact that surgery alone, many situations, will cure patients. So if you follow patients long-term after surgery, many patients actually do not develop long-term problems. But there is this subset of patients that develop metastatic disease, and ultimately that metastatic disease can lead to death. And so in light of that, there's been a lot of data that's actually already been generated in this field. There was a seminal paper by Chuck Peru back in 2000, subsequent papers here by Sorley, showing that there actually are molecular-derived subtypes of breast cancer. And these molecular-derived subsets actually lead to marked heterogeneity in the outcomes of patients. Here you can see on the right-hand side of the screen, there's two different data sets, and people refer to these subsets as the luminal A, the luminal B, the HER2 positive. You're very familiar with the HER2 positive type of breast cancer, and the so-called basal or triple negative breast cancer. So this actually has already revolutionized the care of breast cancer, and we use this every day in our practice. Well, how do we use this information? Well, one of the things that we do know, of course, is that in the case of women who've been diagnosed with breast cancer, is that you saw that slide with regard to the heterogeneity. And that is that when some women who present to their doctor's office with breast cancer already have circulating tumor cells and micrometastatic disease present in their bone marrow or somewhere in their body. These cells are not detectable by routine means, and yet if you follow these patients long term, a substantial number of them will actually go on to develop metastatic disease. And so one of the concepts that was developed way back in the 1960s was this idea of multi-agent chemotherapy. That is, chemotherapy delivered after surgery to eradicate or control these distant metastatic disease or these cells that are being harbored by patients unknowingly. Here you can see that in this particular study, 20-year follow-up published in the New England Journal of Medicine, multi-agent chemotherapy led to substantial improvements in long-term disease-free survival and overall survival. But I want you to notice one thing here, is it took 20 years to follow these patients, and it took 386 women. Now, we're going to move forward now to 2014. There are better drugs. And if you look here you see a study that was just published just a few months ago in the Journal of Clinical Oncology. And now we have better drugs. We have, these are 3 different drugs that have become the standard for treating breast cancer. And you can see that at 5 years, 80% of patients are alive and free of disease. But notice that as these investigators were studying these new drugs, it took 5,000 patients, and they had to follow these patients for upwards of 5 years to be able, in this case, show that there were no difference between these particular drugs. So a couple take-home messages. Number one, breast cancer, there is great heterogeneity. Number two, some of the chemotherapies that have been developed have improved the outcomes of patients. But number three, there are still women that develop recurrence. So we need to take a new approach, if you will, to managing and treating these patients.
So the approach that we've been increasingly utilizing in our clinical practice has been moving the chemotherapy so that it is actually delivered before surgery. So this is kind of one of my favorite slides, and it's always nice to make a joke out of myself. But the top half of the slide kind of shows that historical approach that many patients still expect, which is if they present with a lump in the breast, that the first person that will treat them will be the surgeon who will excise the tumor, essentially render them disease-free, and then the medical oncologists usually come into play post-surgery, at that point recommending chemotherapy agents. The chemotherapy is delivered, and as Dr. Goetz showed us, we have to follow these patients for a long time, and we have to have thousands of patients really to see any difference in the impact on their outcome by the therapy that we delivered. So increasingly now, we're trying to use the approach that's shown on the bottom half of this slide, which is use of chemotherapy in the neoadjuvant setting. So when a patient presents with a breast tumor, they're evaluated by both the surgeon and the medical oncologist. And if they are in that group of patients where we know clearly that chemotherapy will be advantageous for those patients, then that chemotherapy is often delivered in the neoadjuvant setting. What that means as a surgeon is it renders me the trash collector to kind of clean up after the chemotherapy has had its best odds at treating the disease. What that means is that the pathology report from surgery really tells us the impact that these drugs have had on that woman's individual tumor. And what's really novel about this approach is that the studies have shown that the amount of disease left post-chemotherapy correlates with that patient's outcome. So now we have a modality where by treating these patients with neoadjuvant systemic therapy, just 5 to 6 months after their diagnosis, we already have a way to predict how these patients are going to do in the long run. So that means we can study less patients quicker and make moves to improve our systemic therapy now rather than in 10 years' time. So these are the left side of this slide shows kind of the overall summary of some patients who were treated with neoadjuvant chemotherapy, and the green line shows those where the chemotherapy completely eradicated the disease, so no invasive disease in the breast or the lymph nodes, and those patients do reasonably well. Whereas those patients that have residual disease, failed to eradicate the disease with the systemic therapy, tend to have a poorer overall survival. And in fact, this endpoint has now been accepted by the FDA, and they've acknowledged that they may grant accelerated approval of drugs and get these systemic therapy drugs available for patients in the clinical practice based on this endpoint of pathological complete response, which is felt to be a reasonable surrogate endpoint for overall survival. So how can we take this and move this forward towards a true individualized, personalized medicine approach? What do we need for that? Because we know that many of these women treated with neoadjuvant chemotherapy are still at a high risk for failure, high risk of developing distant recurrence and ultimately succumbing to their disease. Well, we need to be able to accurately characterize the tumor mutational landscape, and we're having increasing ability to do that with decreasing cost. We need to identify new drugs, or maybe it's not new drugs, maybe it's drugs that are available but that are not currently thought of for use in this tumor, and use them to test them in tumors that are resistant to current standard therapies for breast cancer. And then we need a better tumor model, and for this study what we've been using is patient-derived xenografts, which you'll learn over the next little while gives us an ability to assess that drug in that patient's individual tumor within a mouse model. So really, as I think about beauty, I think it brings three critical things together in one study. It brings the treatment with neoadjuvant chemotherapy, which provides a response phenotype in a short time frame so we can assess the impact of our treatments. It uses genomic sequencing to identify drug targets for drug development, and then it uses patient-derived xenografts as a viable model to test drugs in the mouse. So this is the schema of the study, and we activated the study in March of 2012, and we've enrolled 140 patients through May of 2014, so just over 2 years. These are all women with high-risk tumor biology, invasive breast cancer, treated by their local treating physicians and determined to be recommended to receive chemotherapy in the neoadjuvant setting. Up front, these patients underwent repeat biopsies of their breast tumor with about 6 to 8 cores taken for research purposes, and these cores were used for both genomic sequencing and also to develop the mouse avatars. We also obtained blood samples for germline sequencing. They then received their chemotherapy, and we delivered the taxanes first, which is a very cutting-edge approach to give the taxanes first and has provided us with a phenomenal resource of data in terms of taxane response. And post 12 weeks of taxane, we repeat the imaging and have another biopsy to see how has that tumor responded to the taxane. They then complete their standard of care chemotherapy with the anthracycline portion of their chemotherapy. And then when they undergo surgery, we also collect the tissue from the surgical specimen of any residual tumor that is still viable post 20 weeks of chemotherapy and use that again for sequencing and also to develop the mouse avatars.
So these biopsies are utilized in a number of different ways. First thing that's used for these biopsies is, as Dr. Boughey said, is to obtain sequencing. So several cores are immediately sent to the laboratory where we obtain exome sequencing, RNA sequencing, methylation. We also are sequencing the germline, and we'll tell you a little bit about those data in just a moment, as well as proteomics as well. Additionally, xenografts are developed, and as we will talk about, these biopsies are put into the mice within about 30 minutes. This requires a large team and a coordination of effort to do this, but as you'll find out, it has been quite successful. So how could we use this particular information? Well, as you heard Dr. Hudis say, is that one of the things that we're required to do when we implement sequencing is we have to show value. So in order to show value, you actually have to show value in the context of the standard of care. So if the standard of care is, as I mentioned, to give standard chemotherapy, you really want to understand what sequencing means in light of patients that respond and in light of patients that do not respond. And then based on that, create if you will, both a clinical plan, and in this case, a research plan that will ultimately develop into a standard of care. So the goals in this study would be to what I would call the N of 1. And you're all familiar with this terminology. But what does it mean to have an N of 1 analysis in the midst of a standard of care? We don't really know that because most people have been thinking about doing N of 1 analysis in the metastatic setting. But I would argue that precision medicine is not precision if we're waiting to the metastatic setting to provide the right drug for patients. We need actually to provide the right drug up front, actually ideally to prevent breast cancer in the first place. But clearly in this situation, to prevent the development and the growth of distant metastatic disease. So we'll show you a little bit about those data and why that actually might be important. Second thing is to actually use these data to develop novel biomarkers. So in this particular study, patients received the drug Paclitaxel, a standard of care. It's a drug that's been shown to have value in breast cancer. That is, it improves disease-free survival and overall survival in breast cancer. But clearly we know not everybody responds to Paclitaxel. How was Paclitaxel developed? It was developed in the way that we typically develop oncology drugs. That is, you treat 4,000 women, half the women get it, half the women don't. You see a benefit overall, and then we make the assumption that all patients benefit from that drug. Obviously, that's not the case, but when we bring forward a biomarker into our clinical setting, we obviously want to make sure that we are not denying a patient a drug that has shown value, but conversely, we don't want to give a drug, obviously, that's not going to work. So we'll tell you a little bit about some data that we've generated in this setting. And then finally, and I think and very importantly, and that is to identify biomarkers that are associated with residual disease. Dr. Boughey showed you how important it is to eradicate the disease. Well, are there ways that we can identify those genes that are regulated in those tumors that are resistant to standard chemotherapy? So this is the clinical summary of patients that came onto the study. 140 patients have been enrolled. Here's the first 134. You can see essentially here that this is a high-risk cohort, relatively young, 51 years old, with larger tumors. The mean tumor size was 5 centimeters, and that actually is, from a standpoint of oncology, that is a large tumor that's associated with a poor prognosis. You can see also that from the Ki-67, which is a marker of proliferation, that the majority of these cancer cells are proliferating at a high rate, which is also a poor prognostic sign. You can also see here that the molecular subtype, so I showed you those data early on about how important molecular subtype is. Molecular subtype drives, if you will, the prognosis of patients. And we know that in this study here that about a third of patients have the so-called basal or ER negative, HER2 negative subset, a very poor prognostic group of patients. A third had tumors that were either ER positive, that had high proliferation, or that were HER2 positive. Here what you can see is that here's the very important slide, and this tells you in the midst of or in the setting of standard chemotherapy, that is the standard treatment in 2014, you can see that in the first highlight here, that we're able to eradicate disease in the breast about a third of the time. But notice that RCB3, which is, by the way, is a marker of how much disease is present in the breast, then in about 25 to upwards of 50% of the time, patients are left with a substantial amount of disease in the breast. Why is this important? Because it is these patients that are at the highest risk of developing future recurrence of their breast cancer.
So we're going to go ahead with just a clinical example here to kind of come back to the impact of the patient that we're all centered on. This was a 40-year-old lady who presented to us with a palpable mass. It was a 6-centimeter tumor. It was biopsied. It was a grade 3 invasive ductal. It was this triple negative or basal phenotype, which means ER, PR, and HER2 negative. And it had very high Ki-67. We classify anything above 15% as high, so 88% is a very high proliferation rate. She was clinically lymph node negative, and she enrolled on the study. Here's her MRI scan from when she initially presented, and you see the tumor in the upper outer aspect of the left breast measuring about 6.1 centimeters in size. She was treated with the 12 weeks of taxane therapy, and she came in for her MRI and repeat biopsy post-taxane. And we see a small amount of shrinkage in the tumor, and maybe it's not quite as solid as it was, but she's still got almost 5 centimeters of disease remaining despite 12 weeks of chemotherapy. She went on and completed the remainder of her chemotherapy, the anthracycline cytoxan portion of her chemotherapy, and prior to surgery, her MRI looked like this. And in many ways, many of us would look at this MRI and say, well, that's a huge improvement from where it was when she presented. But there's still a focus of uptake there of about 2.2 centimeters. We discussed treatment options with her. She was interested in a mastectomy, and she underwent her surgical resection. When you look at this pathology report at a relatively superficial level, you can say, well, her tumor's down in size to 2.5 centimeters, her lymph nodes are negative. Hey, that's a pretty good response. But let's take another look at this pathology report. This is still viable grade 3, so high-grade invasive breast cancer. There's still 2.5 centimeters of disease remaining. The tumor is still triple negative, and still has a very high Ki-67, 93%, very proliferative, active, viable tumor. And the overall tumor cellularity is 100%, so their chemo really hadn't touched that focus of disease. So this is an RCB3 patient. If we look at the data that's out there today in the literature, this study from the German group shows the impact of Ki-67 post-chemotherapy in terms of what that means in terms of outcome. And the left side shows for those patients who are hormone receptor positive. The right side shows the hormone receptor negative patients, where this patient would fall into. And she would fall into that purple line. And you can see that about 5 years, you'd expect her disease-free survival to be less than 40%. So here's a young, active 40-year-old lady, and we can already tell 5 months in, just at the time of her surgery, that we have room for improvement on her care. Well, unfortunately, it won't surprise you that about 4 months after her surgery, she came in with some relatively non-specific symptoms, just fatigue and really just not doing so well. And this is her PET scan shown on the right side of this slide. And her liver was biopsied and confirmed that she had widely metastatic triple-negative breast cancer. And so for us, this is a patient that indicates to us that now is not the time to be intervening, but we need to be intervening with these patients earlier and having better options. And we'll be discussing this patient again a little bit later in this talk.
So we're going to talk a little bit about the germline sequencing, again, just briefly. So as part of the analysis, obviously, as Dan Roden said, you don't treat just the tumor, but you actually have to treat the whole patient, or don't treat just the disease, but treat the whole patient. So in this particular situation, it's actually critical to not only understand the level of somatic variation of the tumor, but also, in this case, what is driving the development of tumor in the first place. We all know from the previous talk that BRCA is important, but here what you're seeing is that it's actually more than BRCA. That we were able to identify through a collaborative group and by doing exome sequencing that actually up to 20% of these patients enrolled in our study carried a deleterious or known deleterious mutation that we can say fairly confidently is highly associated or significantly associated with the risk of developing breast cancer. And you can see those genes here. And so this actually was an interesting part of this particular study, because what we did is actually, when patients consented to the study, we actually had them check a box of whether or not they were interested in receiving the results. And as you might expect, a woman that was so motivated to go on the study, most women were actually very interested in receiving these results. And actually 12 patients met the criteria for return of results. And what we did is we focused only on those genes where there was medical management guidelines. So instead of sort of throwing out and opening up the siphon and looking at the entire genome, we said, let's give the patient information where there's value, where there's been shown to be some value. And that is, in this situation, medical management guidelines existed. So as it turns out, there were 8 patients that actually had already gone through clinical testing. They were already shown to be BRCA mutations, and our data simply confirmed that. But there were additional 4 patients that had not undergone mutation testing or had been seen by a genetic counselor. They elected to receive their results. We went on and validated their findings in a CLIA-certified laboratory.
So how about the mice? Where did they come into the picture? It's a question we sometimes get frequently from the patients, but definitely from the research standpoint. Very important to understand the value that the patient-derived xenografts has added to this study. So as Dr. Goetz mentioned, we really try to minimize the time between the patient and the mouse down to less than 30 minutes if possible. And then that percutaneous breast biopsy is injected into the flanks of the mice, usually 2 to 3 mice per patient, depending on the amount of sample available. The mice are fed with estrogen-supplemented water, and then as the tumor grows, once it reaches the finite size, then that tumor is implanted into another mouse. And so we've defined take rate as being the development of a stable xenograft line. That means not only that it grew in the first mouse, but also that it was successfully transferred onto a second generation of mouse and was growing in that mouse. And in general, the studies in breast cancer have shown take rates in the literature around about 35 to 40%. This is one of the earliest studies that used just breast biopsy samples and not surgical tumor samples. And so we've been really pleased to see that our take rates in those patients when they first present have been relatively high. And in particular, we've noticed that the take rates have been highest, as one would expect, with the most aggressive tumors. So triple negative tumors, about 52% we have established xenograft lines in. The ER positive, HER2 positive, 42%. And as one would expect, the luminal A's, which are the tumors that probably are not very aggressive at all, don't seem to be taking in the mice. The other unique aspect about this study is we've also been trying to take the tissue from surgery and inject that in the mice. And of course, we have a smaller number of patients in that group because some patients are successfully having their tumors eradicated by chemotherapy. And often those tumors post-chemotherapy are very hard to get them to grow in the mice. But at this point, we have 6 tumors growing from 6 different patients, 3 triple negatives and 3 luminal B that are active viable tumors despite 20 weeks of cutting-edge 2013-2014 chemotherapy. And what we're seeing in the mice matches what we see under the microscope from the tumors from the patients. It's also really cool to see that we also have some of these patient-derived xenografts established from patients who are known to have deleterious mutations in their germline sequencing, and this obviously is another avenue for us to interrogate further. So what do we do with these xenografts in the mice, and how reliable is it? Can we test a drug in the mouse, and will it behave the same way as it will in the patient, or will it be different? Well, we took the xenografts that we had and tested some of them with the taxane therapy. And if you remember, we gave the taxanes first, and then we have imaging data on these patients post-taxane. So I just want to go through a couple of examples, because this has been some very exciting work. What you see on the bottom of this slide is the MRI of a patient when she initially presented and again had a large area of disease in the left breast. Post 12 weeks of taxane, before she went on to the anthracyclines, you can see here she had essentially a complete imaging response of her tumor to the 12 weeks of taxane therapy she received. Now let's look at her mouse, and if you look at the top half of her slide, you can see that we had the patient-derived xenograft established at about 100 millimeter cubed volume. If we treated that mouse and that xenograft without anything, then that xenograft continued to grow, as shown in the blue line. However, if we treated that tumor with Paclitaxel, the same drug that the patient had been receiving, you can see that that tumor essentially gets treated and disappears in volume. Now, does that happen to all mice? No. Let's look at another example. You may remember these MRIs here at the bottom. This is the same patient that we described to you earlier. This was the patient who really did not have a good response to taxane therapy clinically, and interestingly, her xenograft from when she presented grew despite or in the presence of Paclitaxel therapy. So what was occurring in the mice mirrors what was occurring in the patient.
So going back to this particular patient, one of the questions that comes up is, can we use this information to help our patients? And obviously, that's the reason that we're here, to provide value to our patients. But not only to this particular patient, but also to future patients. So this particular patient, as we talked about, developed a relatively rapid distant recurrence. So again, just to let me explain, these cells were present long before the patient saw Dr. Boughey. They were already present in her liver, they were present in her bone marrow. We couldn't detect them. But what happened, though, was that response phenotype in the breast was a mirror. It was a window, if you will, into what was happening in the rest of her body. So with that in mind, can we identify new ways and new models to test new drugs? So in this particular situation, after doing and looking across the genome, one of the things that was seen on RNA sequencing was an alteration in DNMT3A. So DNMT3 is a DNA methyltransferase. The 3A is the isoform. It's a methyltransferase that's been implicated in a number of different tumors. If you're familiar with leukemia, you know that actually that alterations in this gene have been associated with a particular severe or poor prognosis. And you can see that what we did in this situation is we had this particular patient's tumor, both at baseline as well as at surgery. And you can see here that even over this short period of time, that there has been the substantial development of upregulation of DNMT3A. Now, why is this important? This is important because as oncologists in the past, the way we've actually treated patients in the metastatic setting is by using information with regard to their primary tumor. You can see, however, that making that decision would be the wrong one here, that actually over a short period of time, in this case only 20 weeks, there's been substantial evolution and upregulation of this protein. Well, why might this be important? Well, there's a drug, it's FDA approved, not for breast cancer, but for the treatment of myelodysplastic syndrome or pre-leukemias. And decitabine specifically targets DNMT3A. And you can see here that with this particular xenograft, that in the control or the untreated mice, that these tumors grew very rapidly, but they were growth inhibited in the setting of decitabine. So that's exciting, but as you might imagine, where we need to intervene for this particular patient is not after she's developed metastatic disease, where her overall performance status is poor, and she has a lot of symptoms from her cancer, but where we need to intervene is at a much earlier stage. So the last thing I will just talk briefly about, and that is we've also been able to use this information to identify biomarkers of taxane response. Here I'll just give you the example, it's a very exciting one, but looking across the genome and using RNA sequencing data, we identified an alteration in a gene that's actually associated with chronic kidney disease. This particular gene was actually found to, that when you knock it down, led to substantial effects on growth inhibition, and that's what you're seeing in the right-hand panel, the upper right-hand panel. Essentially what this SNP does is it alters the protein levels of this very important protein. And also what you can see in the lower hand panel is that we know that Paclitaxel inhibits mitosis, and it has very important effects on cell cycle regulation, that in the presence of knocking down this particular gene, that you see substantial effects on cell cycle. Well, what is that ultimately? What's actually happening? Well, we've identified in this situation that this particular SNP regulates the PI3 kinase pathway. This is work that was being done by Dr. Liwei Wang, who is with the laboratory PI of this particular study. She's been running the mouse core, and her laboratory identified that this particular gene appears to be regulating the PI3 kinase AKT pathway, but not in the usual sense. So not in the way that we normally think about through mutations or, for example, effects on PTEN or AKT, but it actually affects the protein levels. And what you see that is this effect is markedly enhanced in the presence of taxanes. Well, what's happened with some of the other patients? Well, we talked a little bit about showing value. So we've identified that in all of the patients who've developed distant disease thus far, we've identified novel targets. By novel targets, that means an alteration in an oncogene or a driver that we think is associated with the malignant phenotype that could be targeted. Well, what does this look like? Well, I showed you the DNMT3A example, but there are others. For example, we identified a mutation in HER2. So this is not HER2 amplification, right, which is very important for the drug trastuzumab, but this is a mutation in the ligand binding domain that confers activation of the HER2 receptor, leading to activation of the PI3 kinase AKT pathway. And there's a specific drug that actually targets that, and this is a drug called neratinib. And this particular mutation was identified, and the patient was subsequently referred for a clinical trial using neratinib. We've identified other mutations as well. We could use the example of, for example, the BRCA1 and BRCA2, where we know that using PARP inhibitors is of value in these patients. But there's others as well, and you can see identifying, for example, that a subset of these patients exhibit androgen receptor pathway activation. This is a new exciting thing that's just been observed in a subset of triple-negative breast cancers. But here's the problem with this. The problem is that what we have to do as oncologists and for our patients is we have to show value. So what we have to do is actually use this data from a research standpoint to then go on and to be able to show that, that targeting and using drugs that target these pathways actually leads to better outcomes. And what a better way to actually use the patient-derived xenografts that are resistant to the standard chemotherapy to show value.
So Beauty has been an exciting project, and obviously there's still a huge amount of ongoing analysis of the data that we've collected to date. But at the same time, we're also moving ahead and focusing on the next trial, what we're calling Beauty 2. And our goal here with Beauty 2 will be to take those patients that are identified to have high-risk tumor biology, as we define this by drug resistance after standard chemotherapy. So those patients that have a significant chance of having residual disease post-chemotherapy, and see whether we can intervene in those patients earlier. Our goal in this study will be to sequence data both from the baseline and also from the post-taxane and post a couple of cycles of anthracycline, and use those biopsies, get the sequencing data, and use that information to match it with a druggable target. And then we aim to use a short window trial before surgery so that we can actually see how, again, is this novel agent impacting this patient's tumor. So our focus will be on intermediate pharmacodynamic biomarkers, and of course the xenografts will be integral to the design of this study to help identify the biomarkers for the responding patients and those that are not responding. So this is kind of our preliminary schema of where we think we're moving ahead in the next year. Patients with high-risk breast cancer, treated up front with the Paclitaxel, treated with the first half of their anthracycline, and at that point, image them and biopsy them. And based on what we see on their imaging and their biopsy, if they still have significant disease on the MRI, if we biopsy them and they still have elevated proliferation rate in that residual tumor, then those are the patients where we want to intervene. Those would be the ones we would classify as a non-responder. And then we would look at the sequencing information from those patients, identify targets, and then give that patient essentially a window of anywhere from 4 to 8 weeks of a drug that's identified based on what we see from the data both from Beauty 1 and from the sequencing of that individual patient's tumor. Those patients would then go on to surgery, and we would have the size on the imaging and the Ki-67 before the novel agent compared with what we see at the time of surgery. And obviously, we hope that there will definitely still be patients who respond very well with standard chemotherapy in 2014, 2015. And for those, hopefully, we won't need to intervene, and they would complete their third and fourth cycle of standard anthracycline cytoxin chemotherapy and proceed to the operating room. But we would still be gaining the information from any of their sequencing at baseline should they have any signs of early relapse. So I think as Matt kind of opened the study, I think it's critical to close this study, just thanking all of the benefactors and the Center for Individualized Medicine, the Mayo Clinic Cancer Center, the SPORE, the PGRN. This has taken a team of people and a team of support for us to complete the Beauty 1, and we look forward to working towards Beauty 2. Thank you.
15 seconds.
Thank you, Matt. Thank you both. We have time for a few questions here, and not surprisingly, we have a few for the two of you. You wrapped on your ideas about what's next in terms of the research and Beauty 2. But I was curious, we were sort of talking backstage during your presentation, what next for your participants who really gave a lot as part of this research? What I don't want to be crass and say, what do they get out of this, but what does happen with them?
Well, we are actively following those patients over at least the next 5 years. And of course, should any of them develop any recurrence, we have the information available in terms of their sequencing information. And so we can move ahead with this kind of N of 1 analysis and look at the data that we have on those patients. At this point, the standard is still to treat them with whatever the standard chemotherapy for newly developed metastatic disease would be. But then if they fail on that, then we can look at what have we identified in the sequencing, can we test something in the xenografts, and then can we approach the patient about considering being treated with that drug.
Here's a specific question on the Beauty study, and it was the germline whole exome sequencing paid for by the patient? Why wasn't a panel ordered first?
So I can answer that. So one of the things that you can see here is that this was research. So when you do research, you can't charge the patient. So nothing in this particular study was charged to the patient that was considered research, and we consider whole exome sequencing research.
Okay, great. What if it wasn't a research project? It'd obviously be a very different
It would be a completely different approach, and I think that would be, and obviously there's increasing data that, for example, as you could see from a number of different studies recently, that it's more than just BRCA1 and BRCA2. It's actually a number of other genes that have been implicated in the development of breast cancer, and these panels are showing potential value. They're also confusing people as well, obviously, because in some situations, the absolute risk for developing breast cancer may be lower. There might be variants of uncertain significance. But clearly there is value, and our goal, obviously, in this particular study is to identify alterations that could potentially be looked at further in future studies.
We have an audience member who asks, what are the differences between the Beauty study and ISB-2 trial?
So I'll answer that because I could see the CC was asking. There's a study called I-SPY.
Oh.
And it's okay.
Thank you.
So actually, I-SPY
is much better.
It's actually it's a very important study that we are participating here at Mayo. Actually, Dr. Boughey is leading. And in this particular study, patients are randomized prior to receiving chemotherapy to either a standard of care chemotherapy or a standard of chemotherapy plus a novel agent. And the goal in that particular study is to actually improve the rates of pathological complete response. So for example, if that study is successful, they will show that a particular drug has value, and overall, patients who get that drug will have higher rates of PCR. So in our study, what we're doing is a little bit different approach, and that is we're actually treating patients with a standard of care. And our goal actually at the back end is actually to identify resistant patients and then treat them. And if we're successful and we can identify those patients that are resistant and then drugs that have value, we actually hope to accelerate the movement of those drugs more into the upfront setting and potentially into I-SPY.
Okay, good. This is another one from our audience. Did your 124 patients who underwent the Germline whole exome sequencing results see a genetic counselor and actually provide verbal consent for the test, or did they simply just have to check a box saying that yes, they were interested? And this questioner comments, it would appear there could be ethical concerns if it was the latter. Were they aware of incidental findings?
So the patients in the consent form were aware that we were doing sequencing of their tumor and of their germline. Patients only saw a genetic counselor based on the clinician's recommendations. So whether in the study or not in the study, if they had a strong family history, if they were recommended to meet with a genetic counselor and the patient elected to meet with a genetic counselor, then they did. And if the patient elected not to, then they didn't, or if they didn't meet kind of the recommended guidelines, then they wouldn't meet with a genetic counselor. We were very cautious about the sequencing data and do we try to let patients know our findings or not. So there was an additional checkbox within the consent which said, in the event that we identify something within your germline, would you wish to know this information? Mm-hmm. And about 97% of the patients on the study did check yes to that. Mm. But then out of those 12 patients, obviously, where we did identify something that met what we predefined in the protocol as something that we would return to the patient. We were very cautious. You only want to return results where there's a medical management guideline. You don't want to return a result that's just going to make a patient go, what do I do with this information now?
Right.
So if they had checked the box that they wanted to know the result, and we did find something that we felt medically could impact their screening or their management, then they were approached not by the physicians and not by a genetic counselor, but by the study coordinator and said, you checked in the box, you'd like to know your results. Do you still want to know your results? There's something that you may want to hear. Would you like to meet with a genetic counselor? And then there was actually 2 visits with the genetic counselor. One was kind of just the general information about what genetic counseling, find out more about it. Do you want to know your result? Was then a second visit. So we were very cautious about the way that we did this, that we did not feel that any patient was at all scared or felt abandoned in any way. And obviously this went through the IRB and ethical review.
Right, right. A lot of conversation involved in each step of the process, it sounds like.
Yes.
We at this conference, I think, as is pretty common in healthcare conferences these days, we've been spending some time talking about value in healthcare and costs and what we get for our money. And so I'm curious, when we think about that value discussion in your area of work, do you think that breast cancer sequencing is now ready for prime time?
So I can comment on that. I think there are emerging areas. So there's 2 parts of sequence. Obviously, there's the germline, and then there's the somatic mutation. There's what we're doing right now in our clinical practice. So we are actually obtaining genomic information, and that information is being used to direct care. So for example, the one that we commonly think about is the Oncotype DX or the recurrence score. There are others as well, but those have been shown to have value. That is, they tell a physician exactly what to do. I don't need to give chemotherapy, or I do need to give chemotherapy. So what about in this situation, that is using whole exome or RNA sequencing? I think in the case of breast cancer, we don't have data as of yet that it provides actual value to patients. But the onus is on us to generate that. Mm-hmm. And so what I think sometimes the cart can get before the horse a little bit and say, we have the technology, we should simply be doing it. We can do the N-of-1 analysis. Simply, and there are clear evidence, there's evidence that that can actually have some value. But what the FDA and what payers are going to say is you have to actually show it that this is actually going to lead to better outcomes. And do I think that we're going to be able to do that? Absolutely. But we have to do it in light of the drugs that we have available right now that actually work for our patients. I could think of it this way. What you don't want to do is, and Dan Hayes, who is a University of Michigan, says that there's actually one thing that's worse than a bad drug, and that's a bad test. Because you can actually take a drug that has value or that provides important survival to a patient, withhold it because you think you actually have a test that actually gives you information, but actually make the wrong decision because of that. So you have to be very careful. And I think that there are areas, long-winded answer, but there are areas where sequencing has really been shown to have value, and that's in lung cancer and colon cancer. In breast cancer, we're not quite there, but I think we will be there.
Okay. Sure. I'm going to try to squeeze in one more from the audience. This is, what is the recurrence of breast cancer with the approach of neoadjuvant chemotherapy followed by surgery?
Very variable based on the tumor biology. So a triple negative tumor or a luminal B is going to be very different. And then also depending on the response. So I think that's where one of our challenges when we treat our breast cancer patients is so many people have talked to their friend that had X, Y, and Z and this report in the media on this. And as we've tried to highlight, there's at the basic level, there's 5 different types of breast cancer. And then within those 5 different types of breast cancer, depending on how big it was in the nodal involvement up front and how it responds to the chemotherapy will impact how that patient does. So for instance, a triple negative tumor has usually been thought of as a poor prognostic tumor, but if that tumor is completely eradicated by chemotherapy, those patients actually do reasonably well. Similarly with HER2 positive breast cancer, with the targeted anti-HER2 therapy we have these days, we're seeing much higher pathological complete response rates. And so those patients that achieve a pathological complete response are going to do much better than those patients that have residual disease. So really a long-winded way to answer your question and say there isn't one answer to that question, unfortunately.
Mm-hmm. Mm-hmm. Great. Well, you both are doing such wonderful work. I think the audience would love to thank both Matt and Judy for today and all the great work you're doing.
Thank you.
Thank you so much.